Good evening, everyone. Welcome to the 24th episode of Endocrine Talk Show. Today, we are going to discuss the topic that is very crucial for every patient that we treat. Exercise is important, but don't forget sleep. We know the clear benefit of exercise for the benefit of cardiometabolic outcome. At the same time, we also need to understand that sleep is not just a period of rest, but a fundamental biological necessity that impacts every aspect of our health. So, keeping this objective in mind, today's topic has been designed by our course director, Dr. Subhankar Chaudhary, sir. He is a director at Department of Diabetes and Endocrinology, Medica Super Specialty Hospital, Kolkata. He is also a former head for Department of Endocrinology, Institute of Postgraduate Education and Research, and SSKM Hospital, Kolkata. So, with this word, I hand over the digital podium to Dr. Chaudhary, sir, and request him to introduce our panelist and international speaker for today's program. Over to you, sir.
Hi, good evening, all our friends all across the country. And we have an exciting session, an hour and a little bit more, I suppose, ahead of us. We shall discuss something which is important, which we discuss, maybe advise our patients, but I think it's extremely important that we in our own lives also try and practice what we learned this evening. I'm sure most of doctors here in India, we shall ask Dr. Flora as to what happens there. I mean, doctors are working long hours and they sort of maybe take pride in depriving themselves of enough sleep or having their meals on time. So we shall talk on the importance of sleep. And we are fortunate to have a very distinguished faculty this evening, which is not just across different parts of the country, which we normally have on other sessions. Today, we also have an international faculty joining in. That's Dr. Gurdeep Flora from California. And he is someone who is both specialized or certified in internal medicine, in pulmonary disease, in sleep medicine, and hospice and palliative care. So, really, thumbs up and a big, maybe, word of praise for Dr. Flora for going through one after the other different specialities. And thank you for joining this evening for us and morning for you.
Thank you very much.
We also have very senior people in the fields of endocrinology as well as cardiology. So we have Dr. Bhagesh Iyer, our good friend, Professor, Department of Endocrinology from St. John's Medical College in Bangalore. We also have with us Dr. Prashant Sahu, cardiologist, senior consultant cardiologist and director, interventional cardiology at Apollo Hospital in Bhubaneswar. We have Dr. Rana Bhattacharjee, who is associate professor in the Department of Endocrinology, Medical College, Kolkata. And we may just share that Dr. Gurdeep Flora and myself are also alumni of this very old medical college. And we also have Dr. Pratush Gangadhar, who is senior consultant in endocrinology at ICRA International Hospital and Research Center, Kozhikode, Kerala. So we have this wonderful panel, and I'm sure we'll have a wide audience across the country. And we talk about sleep. So the main task before the panel, of course, is to keep everyone awake, not let them fall asleep, the audience fall asleep during the talk show, but make sure that they have a good night's sleep today and subsequently. So can we start with our international star faculty, Dr. Gurdeep Singh Flora? So we talk about exercise, we talk about a lot about exercise, and we know we think we know a lot about its cardio metabolic benefit. What about sleep? If you have less of sleep, which is more important? Can we quantify actually? Gurudev.
Yeah, so the beneficial effects of sleep on cardiometabolic health and other aspects of human health has been recognized by healthcare providers for well over 2 decades. But it was not until fairly recently, I would say, at around in the year 2022, that sleep was officially inducted into the Life Essentials 8 by the American Heart Association and the National Heart, Lung, and Blood Institute. So, prior to that, as we know, even in medical school, the four primary, risk factors for heart disease and stroke were hypertension, hyperlipidemia, diabetes, smoking cessation. We left out the family history because once you're born, there's nothing one can do about it. And subsequent to that, they added diet, exercise, and weight management. It was in 2022 that they eventually officially added sleep. And sleep, as we all know, is not only for rest and relaxation, but it is also for repair and recovery. So there's a significant interplay between sleep and exercise when it comes to their effect on cardiometabolic health, as well as several other issues pertaining to maintaining good health. There's also mutual enhancement. So what that means is that if we participate in regular exercise, that increases and improves the quality of sleep, causes improved restoration during sleep, resulting in decreased stress, decreased anxiety, increased relaxation, and also better regulation of the sleep-wake cycle. Now, while that is important, it is also important to know about the timing of the exercise. As our respected members of the faculty know, that during sleep, especially in high intensity exercises, interval and the high intensity interval training, there's a significant surge in cortisol levels. Then there is increase in the hormones of flight and fright, the catecholamines, norepinephrine, epinephrine, and also the core body temperature goes up. So these three things are not conducive to achieving good sleep, especially at around the sleep time. So we try to emphasize encouraging people to exercise during the morning and in the afternoon, or at least if they don't have time, depending on their schedule, to try not to exercise for at least 4 hours before it's their bedtime. Because if the core body temperature is high, if the level of epinephrine and norepinephrine is high, and serum cortisol levels are high, it's not going to be conducive to good sleep onset. Now, I'm sure, you guys know this better than I do, that the cortisol level starts coming down about 30 minutes to an hour after cessation of exercise, whether it is resistance training, high intensity interval training, stretch exercises, endurance training. But the cortisol level does come down, the body starts cooling, and of course the catecholamines also start subsiding. So that's very important, the mutual enhancement between how how regular exercise assists with good quality sleep. By the same token, if we have poor sleep, it decreases the effectiveness of exercise on cardiometabolic health. And similarly, if we have good sleep, it improves the beneficial effect of exercise on cardiometabolic health. And, sleep is reparative, it restores a lot of things. During exercise, basically, there is an increase in the heart rate, increase in the blood pressure, both systolic and diastolic, because, you have to perfuse the working muscles. There's increase in the cardiac output. The sympathetic nervous system is on a surge at that time. So all of these effects have to be sort of calmed down and slowed down during sleep. Otherwise, we are in a constant state of rush, rush, and rush. So what happens during sleep is that the heart rate slows down, and this happens primarily in the non-REM stage of sleep, mostly in the delta wave or the slow wave, that's N3. Then there's a decrease in the blood pressure at night, which is distinct from the increased heart rate during exercise. So all these are restorative mechanisms that happen at sleep to offset some of the heightened level of energy and the rush of all these adrenal hormones and so on, and even to help with repair of the micro tears that we might have during exercise. Then there's a decrease in the cardiac output because the metabolic demands at night are not as much as during the daytime. And of course, the most important thing is that while exercise is predominantly a situation where there is sympathetic overdrive, during sleep, there is parasympathetic predominance. And this, again, is mostly in non-REM sleep. And the incidence of arrhythmia is also reduced significantly. There's only, and here I'm referring to good sleep. I'm not talking about sleep disordered breathing or obstructive sleep apnea, sleep deprivation, and so on. So all of these things like decreased heart rate, decreased blood pressure, decreased cardiac output, parasympathetic predominance, they all occur during good quality sleep and good duration of sleep. There's only one instance where we might have a little bit of arrhythmogenicity, arrhythmias, and that is during REM sleep, but it's not that pronounced as the parasympathetic activity. So that's, in summary, I tried purposely not to go into the, because they're my esteemed endocrine colleagues. So I didn't want to go into the, what happens with the hormonal levels during exercise and sleep. But I'm really interested in two hormones, ghrelin and leptin. The reason is that because many people participate in exercise for weight maintenance. I should mention here that exercise is more for sleep, for weight maintenance rather than weight loss. So if we don't sleep in the evening or at night, if we don't sleep after exercise, then the goal of trying to lose weight is defeated if we do not have good quality sleep. Because during sleep, what happens is that the levels of ghrelin go down. And ghrelin, as we know, increases the appetite. So when the ghrelin goes down, the appetite goes down, and the leptin actually goes up. But when we have insufficient sleep syndrome, when we have interrupted sleep, frequent wakenings after sleep onset, then unfortunately the leptin level goes down and we start gaining weight. So that, that in a nutshell, there are other things like melatonin, the cortisol levels with their diurnal variations that occur during sleep. They're there to offset some of the hormonal changes that occur during exercise, but a lot of them are tempered with good quality sleep, not only in terms of the quality, but also in terms of the duration of the sleep, which is very important.
Sir, I think you have to unmute, sir.
Excuse me?
Yes, thank you. Thank you. Yeah. So, Gurdeep, if I were to put you on a spot and ask, of the two, lack of exercise versus lack of sleep, which would be more detrimental? Can we quantify?
As a sleep specialist and having seen the havoc, lack of sleep, insomnia, interrupted sleep, fragmented sleep can cause on the body, I think lack of sleep is way more detrimental than lack of exercise.
Okay, fine, great. Yeah. We got the answer. Yeah, thank you. Thank you. So, so now we've got a very good sort of background as to how sleep is so important. Can we ask Dr. Bhagish Iyer as to, and Dr. Flora did sort of mention them in the passing. So, what are the different phases of sleep? So, and again, in one phase, he said could be arrhythmogenic. So, is one phase more important than the other?
I think, sir, mainly there are two types of a sleep, NREM and REM. We used to call as NREM sleep and REM sleep. NREM sleep again been further divided into 4 stages, but initial 2 stages is very important. That to second stage is the most important thing. So the quality of a sleep is always decided by the NREM sleep, which lasts around 70 to 100 minutes. One cycle, it's about 70 to 100. This is the one which gives lots of benefit to the health and the body. REM sleep is a very short period, 20 to 30 minutes, wherein most of the time we get your sympathetic tone is high, body is atonic, and sometimes vivid dreams do come. But why it is there, nobody knows. Why the NREM is there, REM is there, we don't know. But what has been found consistently is in all sleep disorders, there is alteration in this NREM and the REM sleep. Both NREM and REM sleep, the things are altered in the sleep disorders. And most important is how much we spend time in a NREM sleep is a more important, and more so in the stage 2 of a NREM sleep.
Okay, right. And since we before we delve further into details, and I would at this point of time once again request all our participants to put in their questions in the chat box so that we can address our expert panelists. There are some questions already, but I think these will gradually be answered, or eventually we will take them up at some point of time. So, can I ask Dr. Flora, so how many hours of sleep do I need as an adult every day?
Okay. So there are clear-cut guidelines at the present time, at least. The jury is still out on this, and there's plenty of research going on. But the current recommendation by the American Academy of Sleep Medicine is to ensure 7 to 8 hours of sleep in a 24-hour period. It's absolutely vital. Now, other than the duration, what is more important is the sleep efficiency. So the sleep efficiency is total sleep time divided by time in bed multiplied by 100. And the ideal thing would be over 90%. So, for example, if we are in bed for 10 hours, the total sleep time should be 9 hours. So that's 90%. But we'll be happy if somebody can pull in 85%. So that is the current recommendation, 7 to 8 hours. The real minimum is 7 hours. But this is sort of a trick that we healthcare providers use, because if we say 6 to 7 hours, then they're more likely to go a little lower than 7 hours. So the minimum is 7 hours, but we give a range. Okay, when we see a patient in the clinic, we tell them, look, you got to sleep 7 to 8 hours every night.
Right. So let's say you may be aware, you may still remember that Bengalis tend to enjoy their afternoon nap. And of course, not just Bengalis. If you go to Italy, there also you will see people napping in the afternoon. So can I afford to have an hour in the afternoon and 6 hours at night? Is that okay?
This is a very good question. So, for example, when we go to sleep, usually, depending on the person's schedule, we may go to bed at 11 and wake up at 6. That gives us 7 hours of sleep. So that would be considered monophasic sleep. On the other hand, where, in certain countries, you mentioned Italy, but just down south of San Diego is Mexico. And the shutters close between 2 and 3. You cannot do any shopping. The same thing happens in Spain and Greece. So it's referred to as the siesta pattern sleep, and that's about an hour. And the reason for that is, it's not because it's a habit or it's a lifestyle. That follows the circadian rhythm pattern. There are 2 times during the day where the circadian rhythm kicks in, and one is at between 1:30 and 2:30, where, say, a group of office workers go, they have lunch, they come back, and then they start dozing off, and they blame it on the rice, maybe on the MSG in the Chinese food, or they blame it on something else. But no, that is one of the circadian rhythm where the core body temperature goes down a little bit by about 1 to 2 degrees, and the people start dozing off. The second part of that circadian rhythm is between 10:30 and 11, where the melatonin goes high, the core body temperature drops by about 1 to 2 degrees, and of course, the homeostatic pressure, the sleep pressure of having stayed awake for the entire day, all three of them kick in at the same time, and you go to sleep. But a little bit of that happens during the siesta pattern sleep, and that's a normal phenomenon. And there's nothing wrong with it. So if that is monophasic sleep, if you sleep between 11 and 6, that 7 hours is monophasic sleep. But for some unknown reason, because of a party, because you had a tight work schedule, you had to overstay, and you managed only 6 hours that night, you can play catch up the following afternoon by sleeping. So that's biphasic sleep. And there's also another called polyphasic sleep, where people have to wake up frequently. It increases the productivity, but nobody really knows or can prove that there is any benefit or if there's any restorative component of sleep during the polyphasic sleep. But I can say with certainty that monophasic sleep and biphasic sleep are most definitely of equal efficacy.
Right. Right. Yeah, thanks. So that addresses a question we have got in the chat box. This I wanted. What about afternoon sleep in addition to regular 7 to 8 hours of sleep at night? Is it harmful or beneficial? So at this point of time, we don't think that's harmful, right?
It is definitely not harmful. But the thing is, the thing to remember is that it should not exceed 1 hour, because if the nap exceeds 1 hour, then it is essentially taking away from the nighttime sleep, because the sleep pressure that we have, the homeostatic mechanism, as we know, there are two. One is the circadian rhythm, and the other is the homeostatic pressure, the pressure to sleep because you've been up throughout the day. So as long as the nap is 1 hour, it will not interfere with the nighttime sleep.
Great.
But while I'm on this, I just want to say that there's a lot of office workers nowadays I see in India, here in other countries, that when they do feel sleepy at work, they go with the Red Bull, they go with other, caffeinated drinks. That is a no-no. We don't encourage that, because as we know, caffeine has a very long half-life, and it can linger on. Any caffeinated products that we take after noon will interfere with sleep. And so if you have that, that's your body trying to tell you that it is time, the situation is correct, you should actually be sleeping. But there are other ways of trying to, can maybe participate, discuss with your colleagues and so on, and stave that, because it's only, that pressure to sleep is only for 1 hour. After you can maneuver through that 1 hour, you no longer have that pressure. But a lot of people succumb to that. Red Bull is quite common.
Yeah. So we now come to maybe more of endocrinology, let's say, and we have Dr. Pratush to tell us about the hormonal changes during sleep. From an endocrinologist perspective, what are the important things that are happening in sleep?
Okay, sir. Hope I am audible now.
Yeah. Yes.
Yeah, thank you, sir. So during sleep, there are several hormones exhibit significant changes. So it's a complex process. And these regulatory processes actually needed for the growth, repair, and maintenance of our body. So key hormonal changes happens actually needed for the maintenance of physiological homeostasis and support the growth and repair process. So if you look at the major hormonal changes that happen, growth hormone generally increases. Secretion peaks during deep sleep, and this is the first one that started increasing in the first few hours after the onset of sleep. And this hormone promotes actually tissue growth and repair, protein synthesis, and fat metabolism. So it's an anabolic hormone. So the healing process happens during the night, and there are other purposes as well. But briefly, that's the major thing. Melatonin, as we all know, this is a key hormone that regulates the circadian rhythm. That also increases. Its levels start rising during evening and peaks during night. And this is, as we all know, secreted from the pineal gland, regulate the sleep-wake cycles and induce sleepiness. Then if you look at cortisol, it has got a different, probably a different phase of activation in comparison to growth hormone. And growth hormone generally start rising after initiation of the sleep, while generally cortisol decreases in the initial part. Probably there is a hypothalamo pituitary adrenocortical axis suppression in the initial part, and it reaches the lowest point during the first few hours of the sleep. And then in the early morning hours, it actually helps to prepare the body for wakefulness and the day activity. So cortisol levels start rising in the later part. And other important hormones like prolactin also rises during sleep, and it particularly happens during deep sleep, and it has got some role in immune system regulation and reproductive health. And being an endocrinologist regarding insulin and glucagon, generally there is a decrease in insulin secretion because during sleep, the body demand for glucose is lower, and the regarding glucagon, there should be a slight increase or it could stay stable. And another two important hormones like leptin and ghrelin, as Gurdeep sir mentioned, it there is an increase in leptin actually, which is a suppressant of appetite, which increases during sleep, and actually increased leptin secretion helps the body to reduce our hunger and satiety during sleep, while there is also decrease in ghrelin during sleep. And regarding thyroid hormone, it shows the biphasic pattern, and TSH level generally increase during the early part of the night and then decrease towards the morning. And TSH regulates the thyroid gland, and we know that it needed for the metabolism control. So these are the major hormonal changes that happen. And this is the in a nutshell what more important changes that happens during sleep. Sir.
Right. So the growth. So one very interesting thing that I've noticed, for which I do not have a very good explanation. Hope you have one. Is that we know growth hormone increases in sleep. We also know growth hormone increases in exercise. I mean, there's an exercise test to look at the growth hormone reserve, how much it increases. So what could be the possible reason, both in sleep that's suppressed and also in exercise, growth hormone rises? What's the purpose? Any idea? I mean, I don't have. You just muted yourself, Pratosh. Yeah. Was I audible?
Hello.
Yeah. Am I audible?
Hello.
Yes, sir,
Am I
you
audible
are.
now?
No. Maybe Pratosh can't hear me. Pratosh, am I audible to you?
Yeah, you are audible, sir.
Okay.
You are audible, sir. Am I audible now?
Yes.
Am I
We can hear
audible?
you. Yes.
Yes, you are.
Okay, so some issue with the connectivity of that microphone. So the question is regarding the GH secretion occurring during sleep, which is a state of rest, and during exercise. Both state there is an increase. There is a teleological explanation focuses on the basically if you discuss whether what is a teleological explanation, it actually focuses on the purpose or end goal of the process rather than mechanistic details. So during sleep, the primary purpose is to support the growth, repair, and maintenance of the body tissues. So we don't have probably mechanistical explanations, but this must be the purpose
for
of
sleep
growth
and for
growth hormone
exercise.
secretion. So it
Right. And
for exercise, it is actually exercise, both aerobic as well as resistance training. The thing is that muscle growth and repair happens with resistance training, and generally these muscles and promote protein synthesis. Also, fat utilization, especially during aerobic exercise, visceral fat utilization and lipolysis happens, especially because of the growth hormone effect, and it would be useful for the visceral.
Okay, yeah, fair enough. So maybe there's some connectivity issues at Dr. Pratosh's end. So while on the issue of hormonal changes, can I ask Dr. Rana Bhattacharjee about the contribution of melatonin to sleep? And we have had reference to it from both Dr. Flora and also Dr. Pratosh. So if someone has got disturbed sleep, has got insomnia, has it been shown that it's because of low levels of melatonin? And so should melatonin be a logical choice for treating insomnia?
So taking the first question first, basically melatonin is a relatively less discussed hormone in our endocrinology day-to-day conversation. However, it's a very important endocrine hormone, which is hormone secreted from a small endocrine gland, that is pineal gland. And we all know that there is a close relationship with light and dark. And hypomelatonemia is a condition which is possibly relatively recently recognized. There can be some hereditary factors like some genetic mutations, or there can be some acquired causes like some tumor leading to destruction of the melatonin gland. We know the tumors like germinoma usually does it. In some situation like aging, with age there is a suppression of melatonin. The cause may be multiple. One of the interesting thing is that a few weeks back I read about, Dr. Flora may identify that, we know that there is a separate photoreceptor for melatonin suppression. And that is different from rod and cones, that is known since long. But however, it has been seen that with age, somehow the rods and cones can also send signal to the pineal gland, which was not there in young individuals. So the sensitivity to light is also increased with age. So this is relatively new information, at least to me, which I learned just a few weeks back. And there are some drugs, particularly the sympathomimetics, they also said to influence the melatonin secretion. And of course, the more common thing like exposure to light, even with eyelid closed, the presence of light can cause a suppression of melatonin secretion, and shift work, which of course disrupt the natural sleep-wake cycle and impair melatonin secretion. Now, regarding the therapeutic role of melatonin, I think this shift work part and a kind of related condition, that is jet lag, due to the shift of time zone. These are the two classical indication for this melatonin therapy in insomnia. Regarding the other problems, I am not very much aware. I don't really know the evidence regarding the other causes of insomnia.
Right. So we have had our cardiologist colleague waiting in the wings for long. So it's time for Dr. Sahu. So we all have heard about sleep disordered breathing, and we have heard about obstructive sleep apnea and its association with hypertension and also a host of other things. And there seems to be a strong association between the two. However, it's suggested that many of the studies were actually vitiated because of numerous confounders, age, sex, whatever, alcohol intake. So, do you think that obstructive sleep apnea causes or aggravates hypertension? One. And secondly, when do you test for obstructive sleep apnea in your hypertensive patients? If at all you do.
Yes. Good evening, Professor Chaudhary and all the panelists. In fact, obstructive sleep apnea forms an important part in a workup of a patient who is basically resistant hypertension. That is one thing. Your studies have shown that almost 30 to 50% of the patients who have obstructive sleep apnea do have hypertension, and vice versa is also true. Now, if you try to analyze the factors why obstructive sleep apnea aggravates hypertension, the first thing is that these patients usually have some periodic hypoxemia. And moreover, they have frequent arousals at night. They keep on snoring and they are aroused either on themselves or by the partners. And basically, many of these patients are sleep deprived. And all these three factors, like periodic hypoxemia, frequent arousals, and lack of sleep or sleep deprivation, do activate the sympathetic nervous system. And once the sympathetic nervous system is activated, the chances of the patient has more risk of developing hypertension. Now, it has been seen that the patients who were studied with resistant hypertension, when we saw, it was seen that these patients had high aldosterone levels and high intravascular volumes also. So that is why these patients, when they're subjected to aldosterone receptor antagonists, they did well. Especially, it has been now recommended that those patients with obstructive sleep apnea who are not controlled with regular antihypertensive drugs, MRA possibly can be added to get a good result. Now, regarding the second part of the question on when we should screen, definitely patients who are under stress, who are hypertensive, where you don't find even after doing an ambulatory blood pressure monitoring and you see that the nighttime control is not good. These patients do snore at night or have features of sleep apnea. It is very essential that these patients should be screened. Yes, regarding the question that do you screen for obstructive sleep apnea? I do. I do send them to the pulmonologist, especially the obese patient, the dysmetabolic patients who have multiple risk factors. We nowadays get a lot of these young individuals who are overworking at night and do have in the morning also features of obstructive sleep apnea. I do refer them to the pulmonologist or the sleep specialist to get a workup done. And I've seen that after they're put on the BiPAP or they're put on the CPAP, they do have a good weight loss. And their hypertension is well controlled, the diabetes is well controlled, and the weight is also well controlled. This is my take on it.
Okay, thank you. And we have Dr. Divakar asking a related question. Sleep apnea and resistant hypertension are very common. Most of the time, patients are not willing to take CPAP. What are the alternative options? Any comments on nasal dilators? Maybe Dr. Sahu or otherwise Dr. Singh, Gurdeep Singh Flora. Dr. Sahu, would you like to respond?
Means if they're not ready to take CPAP or this thing for their sleep apnea. See, most of the patients, many patients, we have seen that they do take this thing CPAP, but after some days they find it very difficult to continue. Possibly, when you again recheck them, you see that they are not using the devices properly. That is something what you see. We again send them to the sleep specialist and the monitor do sleep studies and they try to see what is going wrong. But the main key is that we should try to see that they are being well monitored, they are taught the proper way to use the device so that the patient benefits from in the long run. This is my take.
Right. Dr. Flora, I think I also share the comment that Dr. Divakar made that many of our patients, despite having demonstrated moderate, severe obstructive sleep apnea, somehow do not continue to use the CPAPs. Maybe the devices are not user friendly or whatever. I mean, they should actually get more relief and they should actually get hooked to it. Do you see that in your patients as well there?
Yes. So there is an incidence of about 17 to 20% of CPAP non-compliance. And the primary cause of that is claustrophobia. A lot of people do not like to have masks on their face. They feel suffocated, especially when you're having a problem with breathing. Now you have a device that is closing over your nose and your mouth that adds to the anxiety level, and they get claustrophobic. So these are the patients that we refer to as CPAP intolerant patients. However, they have come up with various forms of device for the nasal piece. The machine remains the same. So they have the nasal pillows, which is just like putting on a nasal cannula for oxygen. So it's not really suffocating them. It's not going over their nose or their mouth or a full face mask. So that's one of the alternatives that we can do. Then for patients with mild to moderate sleep apnea, when they are CPAP intolerant, we refer them to the dentist to put in what we call a MAD, a mandibular advancement device. So they get all the craniometrics and they get measured, their skull, if they have hypognathism or they have macroglossia, which occludes the upper passage. So they do all the calculations and the measurements, and they come up with a customized device which they put on at night to bring the jaw forward, and thereby the tongue is also brought forward. So that's another alternative called mandibular advancement device. And of course, if we really, sometimes there is severe sleep apnea and we really need for the patient to use it. So we send them for cognitive behavior therapy. They go to the psychologist and so on. There is a new thing that we use here lately, which is becoming quite common, is the Inspire therapy. So what the Inspire therapy is, it's like a pacemaker. It is put under the skin, and it has a sensor that goes to the chest wall. It attaches there, and the other wire goes to the hypoglossal nerve. So there are certain criteria. The person must have a BMI less than 35. The person must be above 18 years of age. The apnea-hypopnea index should be between 15 and 65. And they have to have an examination of their oropharynx, which is drug-induced sleep endoscopy. So, not during their natural sleep, but it's a drug-induced sleep endoscopy where the ENT specialist goes down the throat. If they have concentric narrowing, then they are not considered to be good candidates. But if they have, erratic narrowing and there's not concentric narrowing, then the patients will qualify for the Inspire. So when the chest wall moves, that sensor recognizes that movement and sends a message to the hypoglossal nerve, and that draws the tongue forward and thereby opens the airway. So the Inspire therapy is becoming very common, but as I mentioned, those are the certain criteria that one has to meet before being eligible for the Inspire. And, if you're claustrophobic, you can use it and so on. Yeah.
Right. Okay. So I'm not aware whether this is available to our patients in India. Possibly not. Right. So we come back to the endocrinologist, Dr. Bhazi Iyer. So we have understood that disordered breathing, possibly during sleep, can cause metabolic disturbances. But which comes first, do you think, when we link sleep disturbance with metabolic disturbance? Which comes first?
I think if I think properly, sleep disturbances are leading to the metabolic disorders. I am from a city of IT. In fact, when I started my residency in medicine way back 30 years back, hardly we had a prevalence of a diabetes, even the IT companies here. Now almost in the past 20 years, so many IT companies have come. I have seen in my practice, if somebody is working in the night shift, especially in the transatlantic zone, in the 3 years, we have found them, they are becoming obese, turning out to be IGT or a diabetes. Probably what I feel in the trend we are seeing also, the literature supports the lack of a sleep leads to the metabolic disorder. There is also a lot of hypothetical and also hormonal support for this thing. Whenever we delay sleep beyond 11 o'clock, the cortisol increases. We know that cortisol kicks up the appetite and the person ends up eating and puts on the weight. And also persons with a sleep disorder, their sympathetic drive is more. When sympathetic drive is more, again the cortisol goes up, adrenaline goes up. All these things again kicks up the insulin resistance, IGT, and type 2 diabetes. I feel sleep is the most important thing. And also the studies have found that less than 5 hours and more than 9 hours. It's a U-shaped relation again. It is not only the one linear. Less than 5 hours and more than 9 hours is linked to the metabolic problems.
Right. So maybe an extension of that, can I ask Dr. Rana Bhattacharjee as to the relationship between sleep deficiency and rising diabetes incidence? What would be the potential underlying mechanisms there?
Right. So, actually, there can be it can be multifactorial, in fact, because there can be a widespread change in our body when we are deprived from a proper sleep. And of course, endocrine imbalance plays a major role. And as described by Dr. Vagish, as well as Dr. Pratosh and Dr. Flora, that cortisol is possibly the key here. So inadequate sleep increases the cortisol production, which is a very important counter-regulatory hormone of insulin, and therefore the increased chance of diabetes is there. Plus, there is also a role of leptin, and we know that leptin is a very important suppressor of appetite. And with the sleep deprivation, the leptin secretion, it diminishes. And what happens that many patients also experience that when they wake up, they feel very hungry. They often raid their fridges, and the caloric intake also increases that way. Plus, there is also some role of ghrelin as well. There is some studies which show that there is a increase in ghrelin secretion with sleep deprivation that also contribute to the increased appetite, in addition to the lowered level of leptin. Plus, there is also some evidence of increasing insulin resistance with sleep deprivation. In addition to that, there is also a potential role of systemic inflammation, which can also contribute to the development of diabetes. So, just like lack of exercise, lack of adequate sleep also possibly contribute to the development of diabetes, particularly type 2 diabetes.
Right. So we are gradually understanding as to how sleep deprivation could actually be harmful to our body. We have a question here. Maybe Dr. Pratosh, if you would like to take Dr. Varma. He's commented about some recent studies suggesting that GLP-1 receptor agonists are useful for treating sleep apnea in obese individuals. How useful would such be compared to CPAP? Should we recommend those? Incidentally, so Pratosh, first your comment.
Yeah, so GLP-1 receptor analogs, as we all know, they are very good agents. Now we know semaglutide and tirzepatide are very good agents that can lead to significant weight reduction to the tune of 15 to 20. Now dual blockade can lead to more weight loss. So definitely we can try this if the patient cannot tolerate CPAP, because weight loss is the alternative modality for benefit in patients who are having obstructive sleep apnea related to obesity, and definitely it leads to metabolic benefits. And whether it has got direct effect through the sleep-wake cycle in the through the axis, hormonal axis or not, I'm not very sure, sir.
Right.
I'm not very sure.
Right. Okay. Can I just ask Dr. Flora, do you use these agents, and you have more powerful agents in the US available, dual GLP-1, GIP agonist, tirzepatide, and so on, for your patients, maybe for metabolic benefit?
Yes, so we have been using them for glycemic control, as well as now more recently in the last year for weight loss. Now, we have not been using it for treatment of sleep apnea. And the reason for that is that, yes, weight loss can contribute to reduction in the AHI episodes, but one has to remember that the mechanism of obstructive sleep apnea is not entirely due to redundancy of tissue, the short, thick neck, the Mallampati scores going as high as 3 and 4. We have patients with ideal body weight who also have sleep apnea, and the mechanism for that is because of increased pharyngeal compliance. They are perfect. If you walk in the mall and you see a skinny person, he would be the last person you would suspect of having sleep apnea. But little do we know that when he goes home at night, he puts on the CPAP device. So the mechanism of obstructive sleep apnea is not entirely due to weight, but it can also be due to increased pharyngeal compliance. So yes, it does have a role, because by weight reduction, for those patients who have increased redundancy of tissue in their neck, in their oropharynx, they would, probably benefit from GLP-1. But at the present moment, we're not using it for that purpose.
Right. So we already asked Dr. Sahu as to how he approaches or whom he advises the polysomnogram. So can I ask Dr. Rana Bhattacharjee as to, amongst your patients, maybe diabetes, obesity, how do you pick up your patients for obstructive sleep apnea, for suspected obstructive sleep apnea, and whom would you advise for a polysomnogram?
Right. So, practically speaking, we do look out for the various symptoms and signs, and we also look for various risk factors for OSA. Like important symptoms include that excessive daytime sleeping and loud snoring, which is often a complaint of their spouses, and a peculiar pattern of breathing, which can include a phase of apnea and some kind of gasping or choking. These are also described by some of the partners. And besides this, on examination, if we found the patient is obese and possibly more so in males and with a thick neck, so that is also another factor. I don't remember the exact value, possibly it's more than 40 centimeters is the cutoff where there is an increased risk of the OSA. Now we have more kind of some screening tools as well, some questionnaires. We commonly use A4 sleepiness scale or ESS and stop bank questionnaire. Now there are some studies which showed that basically for screening purpose, A4 sleepiness scale is a very useful one, although it has less specificity. Stop bank has more specificity regarding the picking up of these patients. But overall, we need to be watchful for those who are also at more risk of developing the complications for sleep apnea, like some drivers, particularly who drives the commercial vehicles. So those are also the kind of patients where we have to be extra watchful. And in otherwise, what I feel that a person with unexplained the poor control of diabetes, which cannot be explained otherwise, there also sleep apnea can be a contributor, and we should look into it.
Right. So when we talk of sleep apnea, most of the time we're talking of obstructive sleep apnea. But we know there is also something known as central sleep apnea. So would Dr. Bhagesh Iyer tell us a little bit about importance of central sleep apnea? Please unmute yourself, Bhagesh.
Yeah. Not all sleep apneas are obstructive sleep apneas. There is something more and more we are recognizing with the central sleep apnea. This is very important, especially in a high altitude. Somebody is in the acute coronary care unit, even the post-op, and somebody with the opioid overdosage, either intentional or even following a treatment or a surgery, what we give. It has been found that with increased central sleep apnea, the heart failure, especially very well linked to the heart failure, the outcomes are quite poor. Heart failure output, even the quality and the quantity with the heart failure are quite bad. Even this has been linked to the even a neuromuscular, even a thoracic muscles and the abdominal muscles outcome with the central apneas. I think there was one task force which was I think it was made last decade, and it has come with a recommendation tell I think more and more we need to recognize about central sleep apneas and the outcomes with especially the acute care, coronary care outcomes, and also a heart failure.
Right. So, Dr. Flora, you may or may not remember, but outpatient clinics in India, by and large, are very busy. One physician has to see enormous number of patients. So, can you give our practicing physician who have joined in a quick practical approach to looking at a polysomnogram report? How to interpret that?
Okay, so looking at the polysomnogram report, I think the scoring has to be done by somebody who's an expert, has gone through say 6 months or a year, and they're usually respiratory therapists that have that additional training. So they do the scoring, but in the clinic, what they get is the apnea hypopnea index, then the number of desaturations. So it depends. There are 4 levels of polysomnogram studies. Type 1 and type 2 are conducted in lab setting. Type 1 is a fully attended polysomnogram study. Type 2 is also conducted, and it has 7 channels. It's also conducted in the clinic, but without any attendant. Then type 3 and type 4 can be conducted at home. Type 3 uses 4 channels, and type 4 is the most basic screening tool, where you essentially use a pulse oximeter, you use a nasal flow, and they also use there's a band that checks for the chest wall movement and the truncal movement. So the end result of that is that they give us an apnea hypopnea index, and based on that, we come to a conclusion whether the patient has no sleep apnea, mild sleep apnea, moderate sleep apnea, or severe sleep apnea. As we know, apnea hypopnea index of less than 5 is considered to be normal. Between 5 to 15 is mild, 15 to 30 is moderate, and over 30 is severe. But not only is that taken into account, but we also take into account the degree of desaturation. So the degree of desaturation is actually a lot more dangerous. I know that Dr. Rana had given an excellent thing on the stop bank questionnaire and other screening modalities, but our best friends for referral are the cardiologists, because what they look at is they look at 2 things. One is and unexplained pulmonary hypertension, which cannot be explained by any of their cardiac dysfunctions. And they say, wait a minute, could this be due to untreated and undiagnosed sleep apnea? So when they have pulmonary hypertension, they refer to the clinic. And the other thing is secondary polycythemia. So if a person has secondary polycythemia, say a hemoglobin of 17 and a hematocrit of 60, and there's no explanation for it, right away, the first thing that comes to mind is that could these people be suffering from nocturnal hypoxemia, which actually, causes increased erythropoietin and thereby, the secondary polycythemia. So, those are the screening. But in terms of the physician in the clinic in India, I think just looking at the features of the apnea-hypopnea index, its effect on the oxygen level, how much desaturation is being caused by those apneic episodes, should lead one to sort of start considering the different modalities of treatment.
So what should be a significant desaturation?
Actually, it depends on what the baseline is, but any so it's not only the desaturation, but also the duration of the desaturation.
Yeah.
So if there's a desaturation of 85% or less for more than 5 minutes, that should be a sort of a sign that the person probably needs help. Yeah.
Right. So can I come back to Dr. Paratosh? So I have seen quite a few polysomnogram reports where the AHI is above 5, maybe it falls in, maybe even above 15. So, which will technically make it a moderate obstructive sleep apnea. But if you look at the desaturations, they are not much, they're not there. So do you think those are significant in terms of the metabolic or other harmful effects? Just the AHI, would that be enough?
Yeah, AHI has its own limitations, sir. AHI, moderate AHI, all the guidelines say we need to take into consideration because of the evidence associated with the cardiovascular issues. And if the AHI index is moderate, if it is 15 to 29, then we need to consider. But if it is mild AHI, then probably we need to consider desaturation and the hypoxemic burden. Probably there are new markers. I think Dr. Gurdeep will be enlighten us regarding the hypoxic burden related factors. And I just went across the literature on this, and what they found was that patients who are having moderate AHA, but if the duration of hypoxemia, if assessed by T80 or T90, that is, if the saturation fall is percentage of time spent in saturation of below 90%, then if you took the gradient and based on the different centiles, the people who are having maximum time spent with SpO2 of less than 90%, then obviously the cardiovascular risk in this prospective data is higher. There's a recent literature on this, so probably we need more markers because it has its limitation with the duration and the depth. So probably as intakes. So I think we need opinion on this from Dr. Gurdeep regarding the newer markers and how we can assess from PSG on this.
Right. Maybe we've just stepped over an hour. Maybe we have to wind up soon. But still, we haven't yet got to therapy of at least obstructive sleep apnea. So let me ask Dr. Gurdeep Singh Flora. So when you advise CPAP, is it only for the short-term symptom improvement, as Dr. Dana Bhattacharjee was mentioning, daytime sleepiness and all that, excessive snoring, which affects not only the patient, but also the partner's sleep is affected because of very loud snoring? Or can we justifiably give hope to the patient that your long-term cardiovascular health will improve, or your hypertension control will improve, or your heart failure control will improve?
Yeah. So initially, when sleep apnea is started, there are certain goals in mind that, along with the use of the CPAP, the patient will try to reduce some of the other risks that are causing the obstructive sleep apnea, such as the weight and their level of activity. Unfortunately, if they are not able to lose weight, or if they're not able to improve their Malampati score in terms of the oropharyngeal opening, then they may be stuck to lifelong use of the CPAP. And so, yeah, for obstructive sleep apnea syndrome, unless there's a drastic change in lifestyle habits, I have seen patients who have come back after about a year with a significant weight loss, and now they choose not to use the CPAP. So before discontinuing therapy, we send them back for a nocturnal polysomnogram study. And if it shows that, yes, there is indeed, now they've brought it down significantly, and their, say, the AHI is less than 15 and they're not symptomatic, then there's a chance that they will go off of it. However, all things remaining the same, if there are no changes, then unfortunately the patient will end up being on CPAP forever.
Yeah, but does it help them to decrease the medications for treating hypertension, for example, or heart failure management gets better?
Absolutely. I mean, there's no doubt about it. It's been proven in the literature about patients needing less of their hypoglycemic medications. Their blood pressure comes under control. They may either be able to reduce the dose of the antihypertensive medications or go off of them completely. But this is only as long as they are using it in a compliant manner. Now, the recommendations of using the CPAP are you use a minimum of 4 hours every night for 70% of the nights. So, for example, a person has a trip, say, planned to Europe, or has a trip planned to Thailand, and leaves his CPAP machine at home because he thinks it's a burden to carry it around, then they're not going to. So it has to be a consistent use of the machine, and then only can they reduce their risk. And I've seen people who, after 2 weeks, swear by it, that they're more energetic, they don't have the early morning fatigue, they wake up fully refreshed, they're they don't have the early morning headaches that they had. And of course, the spouse is the happy spouse because of no snoring.
Right. I'm sure across specialties, sleep disturbance, lack of adequate sleep is a problem, and possibly even more so in the field of cardiology. So can I ask Dr. Sahu, so do you prescribe sleep medicines for your patients long term?
To speak the truth, yes, I do sometimes, and mostly not, because it has been seen that first we have to analyze why these patients do not get good sleep. Would we have a tendency at times to give beta blockers at night? And some patients do not tolerate beta blockers. They don't have a good sleep with their beta blockers, or if they're under stress, or if they're having incipient heart failure or some sort of pain they have. So in these patients, we have to first find out what is the reason why they're not able to sleep. Just not go on giving a sleeping pill, thinking that is very easy. But I've seen most of our cardiologists, what they do, that is a bit, seeing 40, 50 patients a day, they hardly bother to ask this question and just write the sleeping pills, hoping that the patient will be happy. It has been shown that if you give sleeping pills to cardiac patients, this diastolic heart failure, or what we call as heart failure with preserved ejection fraction, increases significantly to 8 times. And that is one of the major reasons for
It
hospitalization.
increases.
So,
It
truly
increases.
speaking, yes, it does.
Okay.
It increases chances of diastolic heart failure or heart failure preserved ejection fraction. So it is wise that cardiologists should not use sleeping pills at night. But yes, if they're suffering from any depression, any depressive illness, then definitely there are reasons where we have to give a sleeping pill. But you have to be very selective in a sleeping pill, especially only use the tricyclic antidepressants and not give very strong sleeping pill to them. This is my take on it. Because sometimes what happens, the respiratory drive is also very important for heart failure patients and all. And if the patients have phases of apnea, the chances of failure do increase. So we should be very careful in giving sleeping pills to our patients who have cardiac issues.
Right. So, Dr. Flora, so people come to you for help in their sleep. So, what do you do with them?
Okay, so Dr. Sahu summarized it quite well. So there are pharmacological ways of dealing with it and non-pharmacology ways of dealing with it. Now, there are obviously inherent risks of using sleep medications. The ones that are being recommended by the American Academy are the Z medications: zolpidem, S-zoplicon, and zaleplon. Z. Go to sleep, Z. But they have a tendency to cause confusion. If you have to get up in the middle of the night, you get confused and you might hit the wall or fall. They can cause dependence. And if there is a patient who has undiagnosed sleep apnea, and we are treating these medications for insomnia, it can actually oversedate them and actually unmask sleep apnea. So patients who have sleep apnea, unless they are using the nasal CPAP or some other form of device, they should not be given medications. So we try to focus mostly on non-pharmacological methods. And the first thing that comes to mind is the cognitive behavior therapy for insomnia. But the three main modalities are, number one is sleep hygiene. And what that really involves is, we use the mnemonic of sleep: 7 hours of sleep, limitation of caffeine, alcohol, tobacco, and heavy meals. Don't eat heavy meal before you go to bed. And of course, caffeine is going to keep you wired all night long. So don't do that. Alcohol initially can be sedating, but when the effect of the alcohol wears off in about 2 or 3 hours, then you're wide awake. And it also alters the different stages of sleep. The non-REM 1, 2, 3, and REM, they're all disrupted. You're spending more percentage in one stage where you should be, spending less time. So they all have their inherent, side effects. Number 3 is establish a routine. SLE.
Yeah.
E is establish a routine, a fixed wake-up time, a fixed time to go to bed. Don't go to bed anytime you want, and don't wake up anytime. It has to be so that's part of the sleep hygiene. Then the next E is elimination of all blue light. Stop watching TV 1 hour before. And of course, we're all guilty of the cell phone, unfortunately. We get messages from the hospital and so on. But I think there are certain protective screens. And this is not for everyone. This is for people who actually suffer from insomnia. I have a lot of patients who drink caffeine right before bed and still can go to sleep. So all of these things are problematic only for patients who are susceptible to insomnia, who have problems in going to sleep. So once you eliminate these blue lights and the bright light that immediately cuts off your melatonin, then you cannot go to sleep. And the P is prepare for sleep. The bedroom has to be quiet. There can be no noise. If there's a loud neighbor, and the room should be dark. There should be indirect lighting, the night lights and so on. So those are basically sleep hygiene. Now, sleep stimulus control. Stimulus control basically is the idea that the bed is not your enemy. The bed, a lot of people have in their mind that as soon as I go to bed, I'm tossing and turning, I cannot go back to bed. So what happens is that you sleep when you feel tired. You don't go to sleep just because, 9 o'clock, it's time for bed. No. You go to bed when you're sleepy. Once you go to bed, then what happens is that if you cannot fall asleep within 20 minutes, get out of the bedroom. The bedroom is only for, mind it please, sleep, sex, and sickness. There is no other room for the, there's nothing, no other function for the bed. So when you cannot sleep, you get out of bed, go to the living room, and indulge in some gentle activities like light music. You put on the music. You can read a book, but not with the light on, with indirect lighting, because if you turn the lights on, you're defeating the purpose. So, so those are the kind of activities until you start feeling tired again, and then you try it a second time, and then you come back. So the bedroom should not be used for playing chess or, you know, discussing matters that transpired during the day. And one thing that we emphasize is that, you know, never have a TV in the bedroom. Nobody ever should have a television in the bedroom that, okay, you know, we're going to watch our favorite show, and then when it's done, we're going to fall asleep, because that's not going to happen. That bright light keeps going into your eyes, and your melatonin is virtually zero in your circulation. So that's the stimulus control. And the last one is sleep restriction. So that, you know, a lot of people look at it very oddly. You know, I'm not getting enough sleep, and my sleep medicine doctor or cardiologist or pulmonologist or endocrinologist is telling me you restrict your sleep. And the basis for that is the sleep efficiency. People go to bed and, you know, the same thing, you're in bed for 10 hours, but you're sleeping only 5 hours. So your sleep efficiency is only 50%. So the goal is you do sleep restriction. You wait and keep waiting. Where you were going to bed at 10 o'clock, you just don't go to sleep until it's 1 o'clock or 2 o'clock. But you wake up at the same time every day. So what happens is that you went to bed for a shorter period of time, but you slept for most of that period of time. So your sleep efficiency is improved. So over a period of time, every week you go back, say you go to bed at 1 o'clock, now you feel a little better, your efficiency is better, and you start increasing it by 1 hour every week. And slowly what happens is that over a period of time, your sleep efficiency is improved. So that can be a little problematic in trying to explain to the patients to do. You know, doc, I'm already restricted in my sleep. I'm not getting enough sleep, and you're asking me to do the sleep restriction. And then, of course, you know, the cognitive behavior therapy, we usually refer them to the psychologist who works on them. And they actually incorporate all of these things, the sleep hygiene, the stimulus control, and the sleep restriction in their discussion.
Right. So I think this must have been a very exciting topic, and I'm sure none of the participants went to sleep during this session. And I do hope that they do get good sleep later in the night. And I am informed that this was possibly the record for a number of attendees in a program. I mean, we are having this every month over the last, I think from 2020, we started during the dark days of COVID. So we had the highest attendance in recent times. It was more than 2,200 doctors who keyed in to listen to all the useful advice that we got from all our experts, our overseas, our international expert, Dr. Gurdeep Singh Flora, our local Indian experts, Dr. P.K. Sahu, the cardiologist, Dr. Bhagish Iyer, Dr. Rana Bhattacharjee, Dr. Pratosh, all endocrinologists. So thank you very much for joining in. And I do hope we continue to have good programs in future as well, and hopefully serve the purpose of the physicians and the doctors and the patients. So it's now over back to our organizers.
Thank you, sir.
Thank
Can
you.
I just ask one question?
Yes.
To Dr. Flora, I think we have a concept of getting up early in the morning, what we call it as Brahma Muhurtam. That I think my father insisted right from our young age. You should get up by 5 o'clock. You should not sleep beyond 5. How true it is in current times?
Okay, so those were, spiritual times, and there was no, getting up in the morning and going to the office and attending it at a particular time. Even people used to get up at 3 or 4 o'clock in the morning to pray. The first thing in the morning is that they prayed. Now, during that time, it was most likely okay because they had no real activities in the evening, so they actually went to sleep earlier on. And so the total duration of sleep time was probably enough to meet at least 6 hours. But, it's something similar to nowadays when we have, the advanced sleep phase disorder in older people. They go to sleep around 6 o'clock and they wake up at 2 or 3 o'clock and they become the night owl, or the larks, the teenagers. They stay awake because they're partying, and they go to sleep around 2 or 3 o'clock in the morning, and they don't wake up till 10 o'clock. So the duration of sleep is still the same. It's just that their timings are a little off. So I'm sure even if our parents woke up at 4 o'clock because they had to pray, they had to go to the temple, they still managed about 6 hours of sleep. So I think it had very little impact on them.
But back to the Intas team, and my sincere thanks to the entire team for getting so many people interested on this topic.
Thank you, sir.
Right. So, please.
Yeah. So as we close another insightful episode of Endocrine Talk, so I want to express my heartfelt gratitude to all who made this discussion possible. First and foremost, huge thank you to our esteemed co-director, Dr. Chaudhary, whose vision and commitment have been instrumental in shaping today's session. I also extend my thanks to international sleep expert, Dr. Gurdeep Singh Flora, for his lucid explanation of importance of sleep in medicine and making this discussion meaningful for all of us. My deepest appreciation goes to our distinguished panelists, Dr. Sahu, Dr. Prathos, Dr. Iyer, and Dr. Rana. Your expertise and insight have enriched our discussion, bringing unique perspective that enhance our understanding about sleep medicine and its impact on health. The panel brought in by Dr. Chaudhary today made a significant impact, and we witnessed around 2,500 delegates joining live today. This sets a new record for the Endocrine Talk Show. So I extend my gratitude to all our audience who have joined us from various parts of the country. Until we connect next time, thank you and good night to everyone.